You're welcome to study section 8, Fluid and Electrolyte Imbalance. Almost all medical surgical conditions threaten fluid and electrolyte balance. There may be deficits or excesses of water or of any electrolyte. The assessment and maintenance of a patient's fluid and electrolyte balance is a major nursing responsibility. This study section describes some basic information about water and electrolytes in the body and the causes and effect of common fluid and electrolyte imbalance. When you will have studied this study section 8, you should be able to distinguish between electrolyte balance and imbalance. You should be able to explain all the clinical manifestations of fluid electrolyte imbalance. And lastly, you should be able to apply nursing process in the assessment and management of conditions due to fluid electrolyte imbalance. Extracellular fluid deficit. We will be discussing two extracellular fluid deficits, that is hypovolemia and hypervolemia. When you get to your course material, you can read more about extracellular fluid deficit. Let's start with hypervolemia. Hypervolemia is a condition in which the extracellular fluid compartment becomes expanded and there is a surplus of circulating fluid with normal or near normal proportion of electrolytes. It can be caused by inability of the kidney to excrete excess water and electrolytes as seen in chronic renal disease, chronic liver disease, congestive heart failure, or administration of oral or parenteral fluids at a rate beyond renal capacity for excretion. 2. It can also be caused by administration of intravenous fluid at a rate beyond renal capacity for excretion, especially in patients with impaired kidney function or in infants or elderly people. 3. Fluid retention following administration of large doses of corticosteroid resulting from the increased level of aldosterone. Clinical manifestation of hypervolemia. 1. If excess fluid are in the vascular space, there will be elevated blood pressure, bounding pulse, distended neck veins, weight gain, dyspnea, crackles, and sacral edema. If overload becomes sufficiently severe to exceed the pumping capacity of the left ventricle of the heart, pulmonary edema will result. Laboratory findings are variable. Serum osmolarity usually remains unchanged. Serum sodium values are not often affected, although they may be low. Hematocrit may be decreased as well. Medical management of patients with this condition. Treatment is according to severity, but the goal is to obtain a definitive diagnosis of the underlying cause to determine appropriate treatment. The following should be done in managing this patient. Restrict fluid and sodium intake, administered diuretics, for example, laces to eliminate excess fluid, replace potassium losses secondary to diuretic therapy, administer dialysis for patients with renal failure or life-threatening hypervolemia. Nothing diagnosis for this patient. Fluid volume excess, edema related to surplus of circulating fluid. Now let's go to hypovolemia. Hypovolemia is a condition in which depletion of extracellular fluid occurs as a result of water and sodium loss in varying proportions from the body depending on underlying pathological problems. 1/3 of the loss is from vascular space and 2/3 from the interstitial space. Causes of hypovolemia. 1. Gastrointestinal losses such as vomiting, diarrhea, fistulas, drainage, ileostomy, gastric sunction. 2. Urinary losses from diuretic administration, renal or adrenal disease, diabetes insipidus can also be a cause. 3. Sequestration of fluid. This is with as seen in burns, peritonitis, ileitis, ascites, and acute pancreatitis. 4. Profuse diaphoresis, hyperventilation, fever. 5. Decreased intake of water and electrolytes. Then 6. Blood loss. Clinical manifestation of patient with hypovolemia. 1. Postural hypotension, weak pulse with tachycardia, flattened neck veins, increased respiration, poor skin turgor, longitudinal furrows in the tongue, absence of moisture in the groin and maxilla, decreased tearing and salivation, anorexia, nausea, vomiting, weakness, apathy, weight loss, subnormal temperature, and decreased urine output. Shock and coma can ensue if volume depletion is severe. Medical management of patients with hypovolemia. The goal is to restore extracellular volume and correct the underlying cause. 1. Administer oral or intravenous fluid to replace water and electrolyte losses while definitive diagnosis is being made. Isotonic fluids such as lactate Ringer solution and 0.9% normal saline are given. Blood transfusion may be given in severe shock. Nursing care. Nursing diagnosis for patients with hypovolemia is fluid volume deficit related to abnormal loss and decreased intake. Nursing objectives. Patient's vital sign, physical finding, and laboratory values will be within acceptable limits at the end of the nursing intervention. The nursing intervention for this patient. 1. Monitor vital sign, laboratory values and input and output for evidence of dehydration, measure weight daily, check specific gravity of urine. 2. As appropriate, encourage oral intake or administer prescribed replacement solution. Observe for indication of fluid overload during rapid intravenous replacement. 3. Provide oral hygiene at frequent intervals. And 4. Obtain accurate measurement of third fluid accumulation areas such as the abdomen and limbs. Measure abdomen or limbs at the same place with each assessment. To ensure accuracy, mark the measurement size with indelible ink and use the same tape measure for all assessments. 5. Position patient in supine with foot slightly elevated to allow blood flow through the brain and the heart. And 6. You teach the patient on diuretic therapy, leg exercises, and to rise up slowly from bed. Electrolyte disturbance. The disturbance affects both intracellular and extracellular compartment. When osmolarity in one compartment is altered, water shifts to balance the osmolarity. Sodium is the major action of extracellular fluid and is primarily responsible for osmotic pressure in the compartment. Normal serum sodium concentration is approximately 137 to 114 millimole per liter. This disturbance affects both intracellular and extracellular compartments. When osmolarity in one compartment is altered, water shifts to balance the osmolarity. Therefore, both compartments becomes equally increased or decreased. Sodium. Sodium is the major action of extracellular fluid and is primarily responsible for osmotic pressure in that compartment. Normal serum sodium concentration in the body should be maintained. Body water and electrolyte regulation by the kidney is based in part on sodium concentration in the extracellular fluid. Hypernatremia. Hypernatremia means increased serum osmolality. It could be caused by decreased intake of water due to inability to respond to tests, such as in an unconscious state, less efficient functioning of the test center in the base of the brain, as is commonly seen in an elderly patient. 2. Increase output of water from severe hypotonic fluid losses through the gastrointestinal tract and respiratory tract. 3. Increase urinary water loss through osmotic diuretics and diabetes insipidus. And 4. Increase intake of sodium from excessive administration of concentrated electrolyte mixture. Clinical manifestation of patient with hypernatremia. 1. Intense thirst, flushed skin, and a dry skin may be seen, sticky mucous membranes, or rough reddening dry tongue, elevated temperature, loss of skin sugar, agitative behavior such as restlessness, excitement, convulsion, decreased reflexes, oliguria, and anuria. Laboratory findings for this patient will include serum sodium test, which may increase serum osmolality, urine specificity of greater than 1.030, except in diabetes insipidus. Management of patient with hypernatremia. The goal is to restore normal sodium concentration. 1. Replace water. Plain water given by mouth may be sufficient in the early stage of sodium excess, or if serum sodium is decreased, IV infusion of hypotonic solution of water and electrolyte like 5% dextrose water intravenously should be given to this patient. Note, rapid reduction of serum sodium may lead to cerebral edema, seizure, and death. 2. Administer diuretics by mouth with plain water. And 3. Draw serum sodium levels. And nursing care for this patient. It is approached by finding the nursing diagnosis for this patient and attending to the diagnosis as appropriate. The intervention for the diagnosis for this patient, one of it is fluid volume deficit related to abnormal loss or decreased intake. Nursing objective: patient vital signs, physical findings, and laboratory values are within acceptable limits after the necessary intervention has been given to this patient. The intervention: monitor vital signs and input and output, and assess skin sugar and mucous membrane for evidence of dehydration, check urine specific gravity, and monitor serum sodium level. You can read more on this in your course material. Hyponatremia. Hyponatremia exists when the serum sodium concentration in the given amount of plasma water fall below normal. Some of the causes may be loss of sodium containing fluid from vomiting, diarrhea, etc., excessive diuretics used together with reduced sodium intake, plasma to interstitial fluid sheet, and massive burns and trauma. When you get to your study manual, try and read more about this. Thank you for listening. See you in the next class.